Good afternoon, everyone. Today, I am sharing the findings and trends from recently collected individual-level COVID-19 case data on ethno-racial identity and household income. This information is key to helping my team to understand who is being impacted by COVID-19 in our city and to inform our public health actions. My team added socio-demographic questions to the case follow-up process to help us better understand if COVID-19 is disproportionately affecting certain residents in our city. The data were collected from people infected with COVID-19 and who answered voluntary questions on these topics. These data are collected at the individual level, but are being reported as overall data summaries and trends in order to protect confidentiality. While there are some limitations with these data, they provide powerful insights into how COVID-19 is impacting our community. There is growing evidence in North America and beyond that racialized people and people living in lower income households are more likely to be affected by COVID-19 infection. While the exact reasons for this have yet to be fully understood, we believe it is related to both poverty and racism. Before presenting the data, I would like to take a moment to note some key data considerations. First, the data do not include long-term care home and retirement home residents, as these individuals were not asked about their race or their income. We also acknowledge that questions relating to race and income are of a sensitive nature, and some people prefer not to answer them. I also wanted to share that at this time, we are not providing any data on Indigenous identity because we continue to consult with members of this community on this subject. And last, individuals who were very ill could not respond to all of our case investigators' questions. As I've shared before, collecting and analyzing these data informs our public health response and actions to protect your health. We began collecting these data on May the 20th, and the findings that I will present include data collected up until July the 16th. So the graph on this first slide shows the share of COVID-19 cases by ethnoracial groups compared to the share of Toronto's population. The black bars show each ethnoracial group's share of COVID-19 cases, whereas the larger green bars show the share of the population. Ethnoracial groups that have a taller dark bar than green bar are overrepresented in COVID-19 cases. The majority, or 83%, of reported COVID-19 cases in the City of Toronto with valid ethnoracial data identified with a racialized group. This is compared to 52% of Toronto's population who identify as belonging to racialized groups. The chart illustrates that Arab, Middle Eastern, or West Asian people, Black people, Latin American people, South Asian and Indo-Caribbean people, and South Asian people are overrepresented in COVID-19 cases. East Asian people and those who identify as white are underrepresented. For example, the data indicate that Arab, Middle Eastern, or West Asian people represent 11% of COVID-19 cases, but only 4% of the population in Toronto. And Black people represent 21% of COVID-19 cases, but only 9% of the population. On our website, you will be able to view this graph separately for males and females as well, but the trends are similar. 71% of people who were hospitalized identified as coming from racialized groups, although this is based on a relatively small number of hospitalizations. There have not been that many hospitalizations since we started collecting these race and income data, and that is a good news story. The next slide shows us the same data, but presented as a rate per 100,000 people, using data from the 2016 census as the denominator for those rates. These rates should be interpreted with caution because the census data are now 4 years old, and the distribution of racial groups in Toronto may have changed over this period of time. Census data may also underrepresent certain groups of the population, which may make some rates look larger than they are. However, you can see the same ethnoracial groups have, in some cases, a much higher rate than the rate overall, which is illustrated by the bar, the line across the graph. This is the rate overall for people with valid ethnoracial data, so it is different and much lower than the true current rate in the city. Our data also show that people living in lower income households are overrepresented in our COVID-19 cases. 51% of reported COVID-19 cases in Toronto with valid income data were living in households that could be considered lower income. This is compared to 30% of Toronto's population who meet that same definition. 60% of people who were hospitalized met this definition of lower income. But as I mentioned earlier, for the findings by racialized groups, this is based on a small number of hospitalizations. The graph on the next slide illustrates the share of COVID-19 cases by household income groups compared to the share of Toronto's population in each income group. In this graph, the darker bars show each income group's share of COVID-19 cases, whereas the larger blue bars show the share of the population. You can see that the lower income groups are overrepresented in COVID-19 cases. For example, 27% of our cases with valid income data have household income levels of less than $30,000 per year, compared to 14% of Toronto's population. You can view these data separately for age groups on our website, but the overall message that lower income groups are overrepresented in COVID-19 cases is the same across age groups. On this final slide, the graph shows the same data, but presented as a rate per 100,000 people, using census data once again as the denominator for the rates. You can see that there is what we call a stepwise gradient in the rates across income groups, whereby the two lower income groups have a much higher reported COVID-19 infection rate than the rate overall, which is illustrated by the black line across the graph. This is the rate overall for people with valid income data. So again, it is different and much lower than the true current rate in the city. We have also learned that people living in larger households were overrepresented in reported COVID-19 infections in Toronto. Those living in households with 5 or more people comprised 27% of COVID-19 cases, compared to 20% of the population of Toronto. While COVID-19 has affected all of us, unfortunately, it has had a greater impact on those in our community who face greater health inequities. In the short term, addressing the needs of these members of our community will involve measures such as targeted testing, enhanced communications, and increased access to social supports, such as voluntary isolation sites for people with COVID-19 or those at risk of infection who cannot properly isolate at home. In the longer term, however, if we want to have a true impact, a real impact on improving health, including COVID-19, we need to address these health inequities and get to the root cause of what underpins our overall health. We need to focus on the social determinants of health, like affordable housing opportunities, access to employment and income supports, and educational opportunities. And yes, we need to address systemic racism. This observation on what needs to change in our city has been highlighted throughout this pandemic. I believe that as we continue to expand our understanding of this virus and how it has impacted our residents, we need to better address these social determinants of health to build a more resilient city and better protect all of our residents from COVID-19 and other emerging health threats. I look forward to continued collaboration with health system, community, and government partners on ways to make sure that all Torontonians enjoy good health and realize their full potential in our city. I would now be pleased to turn it over to Mayor Tory for his remarks.
Well, Dr. Davila, thank you for that presentation, and thank you for all of your efforts during the course of the pandemic and before and after. And good afternoon to everybody. I'm very pleased to be here today with my colleague, Councillor Joe Cressy, who's the chair of the Toronto Board of Health, and Dr. Kwame McKenzie of the Wellesley Institute, who that title doesn't do justice to the great role that he's played in a number of areas of our building up our city and making sure that it's the kind of compassionate and caring place that we need it to be. And I want to thank the dedicated team at Toronto Public Health for gathering and analyzing this data that is so critical to informing our ongoing COVID-19 response and recovery efforts, and so much more going on after this pandemic has been put to rest. I truly believe one of the reasons we're having a somewhat better experience fighting off COVID-19 is because of data transparently collected, analyzed, and made available, shared between governments and between different parts of the government, and used in all of our decisions. With this data, we've also been able to help ensure that our response to the pandemic reflects those who are being impacted by it the most, and to try and support them to the maximum extent that we can. From the outset, I have strongly supported Dr. Davila's call to collect data as part of Toronto Public Health's response to COVID-19. And as an important part of our being straightforward with each other about the impact of this pandemic on different groups of people and different parts of our city. It's been important for us to be able to be straightforward, and you can be more straightforward when you have the data to back you up, as you've just seen. I knew that it would play a key role not only in our response, not only in what we could further learn about the virus, but also a key role in making the right decisions. I believe this will also be true of the collection of race-based data, for example, by our police services, something I'm glad we have started to do after many years of controversy and debate, and I think it too will help us to learn and to make better decisions. As Dr. Davila shared, we know how we live and work and play impacts our health. This is true for many other illnesses, but COVID-19 has clearly changed all aspects of our lives, how we work, how we live, and how we play. The data presented today demonstrates that racialized populations and lower income groups in our city are more at risk of contracting the virus, and highlights the inequities that unfortunately continue to exist in our city. They've existed for a long time, and they continue to exist. Although this information is troubling to hear, Again, within this context, having it put before us in stark terms is better for us in our response and in the long term. Toronto Public Health and city staff are sharing these findings and consulting and collaborating with community agencies that serve groups of people who we now know, with evidence, are experiencing higher rates of COVID-19 infections. This will help us to better understand the inequities that continue to exist within our city so that we can plan programs and supports and services that effectively address these challenges. Make no mistake, whether it is evidenced by our poverty reduction strategy, our efforts to eradicate anti-Black racism, or our determination to meet our ambitious goals on affordable housing, this data once again shows us the magnitude of the task before us and just how much of a challenge this inequity represents to our shared collective values as Torontonians. By working collaboratively with community agencies and, of absolute necessity, with other governments, we know that we can address these issues the best possible way. Community organizations are a key partner in this because they know best the communities and neighborhoods they serve. This includes engaging with local community groups to better understand risks and the concerns that residents in these areas have, so that we can work together with them to address those concerns. As for the other governments, we will need to work with them, sharing this data and making new, informed decisions based upon this data. This includes continuing to work with our provincial partners on pop-up testing, which Dr. Davila mentioned, in areas that have been harder hit by COVID-19, and identifying locations for people to self-isolate if they are unable to do so at home. As I've said many times before, I look to our medical health professionals and the guidance of Dr. Davila on our response to COVID-19 and on some of the things that should follow our experience with COVID-19. The data being released today gives us an important opportunity to do just that and to better meet the needs of all of our residents, in particular those who are the most vulnerable in many respects, not just to COVID-19. While I hesitate to always be the one that raises the subject of money, it goes without saying, as we go forward to try to address the broader needs of our residents, but in particular the needs of these lower-income residents and racialized communities who are at greater risk and suffer more illness, we must have a consistent, properly funded partnership with the other governments, since we all know here today that property taxes alone cannot and were never intended to finance these kinds of social initiatives on a scale needed to address what this data tells us. So once again, I want to thank Dr. Davila and her staff at Toronto Public Health for collecting this data. I think that the day we agreed to do this, and we agreed unanimously and collectively to do so, it was a very, very important step forward for the City of Toronto and to advancing those values that we hold dear, and then, in turn, having the opportunity to do something about putting those values to work and making sure they're a reality for everybody. The data is already proven to be useful and will be especially important to us moving forward. May I now turn the podium over to the Chair of our Board of Health, Councillor Joe Cressy, who's also been in the vanguard of leading to have these kinds of changes that can provide us with so much constructive information and so much evidence as to how and where we have to plan.
Well, thank you, Mayor Tory, Dr. Davila, and Dr. McKenzie for joining us. 83%. That's the percentage of all COVID cases involving racialized Torontonians, whereas only half of our population is racialized. 51%. That's the percentage of all COVID cases involving people on low incomes, whereas only 30% of our population is on low income. 83 and 51% . You know, I won't lie, I won't sugarcoat it. When I heard these numbers, it felt like a punch to the gut. You know, perhaps they shouldn't surprise us. We know that race and income have long determined health status, but they do represent a call to action. Now, COVID by no means created these racial and economic disparities in Toronto. They existed long before, but COVID has certainly exposed and taken advantage of them. We've often talked about how we're all in this together. And I will tell you, to my core, in this city, in Toronto, I believe it. We are all in this together. But clearly, and the data shows this, we have more to do. Now, Toronto Public Health took the proactive step of collecting this data because Well, we knew that a virus like COVID was likely to disproportionately affect certain groups. And to that extent, I want to thank Toronto Public Health and Dr. Davila and their team. You know, we have a team at Toronto Public Health and many epidemiologists at Toronto Public Health who are amongst the best in the country. And while science may drive their work, their compassion and their commitment is always present, and that's here today. Now, we can't beat a virus like COVID if we don't understand it. That's why this data is necessary. Collecting and sharing this data is not the outcome. It's not the objective to collect data, but rather using it to guide our response is. That's the objective. This data provides a roadmap to prevention. It informs testing, where and how we test. It justifies and affirms the need for voluntary self-isolation facilities. It guides our education efforts, and it demands long-term policy changes for all levels of government. In public health, we've long known that it's your postal code, not your genetic code, that is the biggest driver of health. The social determinants of health, your race, your income, your housing status, they've long determined who gets sick and who doesn't, who lives and who dies. Sadly, this isn't new. And so when we are presented with data like this, our task going forward is to use it to protect our residents and to beat this pandemic. But I will tell you our duty as decision makers when presented with this type of data is to address these fundamental wrongs. And in that sense, this data provides a pathway to beating COVID, but not only that, it provides a roadmap to building a new and better normal afterwards. With that, I'd like to turn the floor over to Dr. Kwame Mackenzie, CEO of the Wellesley Institute, but for those who don't know Kwame, one of the world's leading experts in health equity.
Well, thank you very much for inviting me to this landmark press conference. As Joe Cressy said, I'm the CEO of the Wellesley Institute, which is a think tank that tries to improve health and health equity through research and policy development. I'd like to thank Mayor Tory for the way he's balanced public health and the economic responses for COVID-19 for Toronto, and also advocated with different levels of government for a fair share of COVID response for Toronto. I'd really like to thank Joe Cressy for his leadership of the Board of Health, and specifically for him championing equity and racial equity in responses to COVID. And of course, I'd like to thank Dr. Davila, partly because she's stolen almost everything I was going to say, but also because of her precise evidence-based pandemic plans, which have saved so many people. So I'd like to start my comments by saying these data are very welcome, but they're also very concerning. They seem to confirm our worry that racialized populations and low-income residents of Toronto are doing worse during this pandemic. The data should lead to urgent action to ensure that we have a pandemic, social, and economic response that works for everyone. And I just want to talk about three things. First, why we should collect data anyway. Second, what are the concerns about collecting data, and then get on to what we should do about it. So why collect data? So we all know now that COVID is not a great equalizer. COVID-19 discriminates. It exacerbates existing social and economic differences. Early in the pandemic, we were focused on flattening the curve. But there was less focus on who was under the curve and whether the pandemic response was protecting all of our communities. This is why so many experts in health equity, and especially the Black Health Equity Initiative, were calling for disaggregated data. And I'm happy to see that we are doing this and that Toronto Public Health has taken up the challenge. But as Councillor Cressy said, the aim was never just to collect data to show that different parts of our community were more at risk than others. The aim was to make sure that our diverse communities were properly protected during the pandemic. The data has to be linked to action. If diversity is our strength, then we should have public health, social, and economic responses that work well for everybody. Data can help us do that. But there are concerns about data. One is that it will be misused, and communities are increasingly wanted to be involved in the governance of their data. They want to say in what's collected, how it's collected, and how it's used. And Toronto Public Health have been working hard to make sure that they've engaged communities, but I think for every jurisdiction, much more needs to be done on data, the issue of data sovereignty and community control. Another concern is that the stories of individuals are lost in the data. Can data alone tell us the stories of racialized essential workers who put themselves and their family at risk to ensure our way of life continued during the pandemic? Can data tell the stories of the people frustrated in trying to protect themselves and physically distance because they're overcrowded and because of Toronto's housing market? Can data tell us the story of the echo pandemic that's happening in school kids who are finding being at home very difficult, and especially in low income and racialized populations because of the digital divide? Data can't do that, but data can help shine a light, and that's why it's important. So, what can be done, and what should we do now? Well, they say that public health is the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society, not just through the actions of public health itself, but through the organized efforts of society. And we clearly need a pandemic response which protects racialized groups and low-income groups. And that means we need to do some things differently. We need our experts to be working with communities and with all levels of government to produce new solutions that will make sure that our pandemic response is equitable. And these solutions need not just to be focused on COVID, they need to make our communities stronger. They need to make them more resilient. This means we need to consider why we have such differences, why there are such differences in risk for racialized populations and low-income populations. And I'll just talk about very quickly two issues that we should be thinking about very quickly. One of the things that has become clear from the data from the Dalla Lana School of Public Health is that the ability to physically distance is one of the most important things to protect you from COVID, on top of obviously testing, tracing, and isolating. The lack of affordable housing leads to overcrowding and decreases the ability to protect yourself from COVID by physical distancing. If we want to protect our communities, we need urgently to increase access to affordable, healthy housing. Our racialized populations are much more likely to be overcrowded. Low-income populations are more likely to be overcrowded. Our racialized communities are also more likely to be essential workers. If we want to protect those communities, we need to properly protect essential workers. We need to protect them at work, but we also need to protect them when they're at home. And one of the ways we can do that is to make sure they're paid properly and they have benefits packages that are befitting people who take such risks. So, this is just the beginning. This is the start. This is a landmark press conference because it is the beginning of a journey. If we want a COVID response and a health system more fitting to Toronto, we need an equity-based COVID-19 pandemic plan. We need social policy and recovery plans focused on decreasing current inequities that put people at risk. And we need data streams and research which allow us to properly identify risk groups, build appropriate interventions, and monitor their impact. If we can put all of these in place, we will move from what's been a good response to what has been a great response. And we live in a great city, and we deserve an equitable and great pandemic response. Thank you very much.
Thank you, everyone. Thanks for joining us today. We will now open the floor to questions. As a reminder, it is one question, one follow-up. First up, we have Mark Douglas from 680 News. Go ahead, Mark.
Hi, can everyone hear me all right?
Yep, go ahead.
Okay, thank you. To a question for either Mayor Tory or Dr. Davila, whoever you think would most like to answer this, or if you both want to say something, that'd be great. Mayor Tory, you said, we know now, we have the evidence. Hindsight is always 20/20. Was there no way, though, of anticipating these sort of this disproportionate impact, this unequal impact of COVID-19? Was there no way to sort of get ahead of this and sort of prevent the segments of Toronto that have been disproportionately hit from being hit that way?
So, Mark, why don't I start with an answer first? I think that, it's always easy to look back in hindsight and think about what we might have done or what we could have done. But what I can tell you is that at that time, when COVID-19 first emerged, there was a lot of uncertainty. New virus, not really, well understood, and there was a lot to understand in respect of transmission and, what the nature of the virus was, how transmissible it was. There were many, many questions. So I think there was a lot of the response focused on that. I think the other element, of course, was that we were using an information system, a long-standing provincial information system that has served us well in respect of communicable disease case management, but did not actually allow for the opportunity to collect these data in a way that they could be acted upon, which is why we developed our own system here at Toronto Public Health and actually incorporated questions specifically on income, on ethnoracial grouping, so that we could understand, we could ask those questions and collect those data in a systematic fashion so that we could use those data. So I think that that really is what underpins our response and why we took the approach that we did. And I think that as good public health professionals and practitioners, one always has to remain humble and seek every opportunity to learn from each of these situations. And I would like to think that that's exactly what we did in this circumstance. Mr. Mayor, I don't know if you have anything further.
Go ahead, Mark, follow up.
Then, Dr. Davila, just to get back to some specifics here, you outlined some of the measures that are going to be brought in to respond to these demographic groups. And I'm wondering, I don't know if I heard this or not, but mobile testing units for certain neighborhoods, is that going to be an option? Is that something that could be brought in?
Yes, and in fact, that's already happened. We've seen pop-up testing clinics, if you will, in various neighborhoods around the city, specifically to address those areas that have, demonstrated greater need. So I think that's just one endeavor and one initiative amongst many. But I will tell you this, as you've heard from the speakers this afternoon, it is incredibly important that these new initiatives, new endeavors to meet the needs of communities shouldn't be done by us alone, but must be done in concert with communities themselves and with other partners, of course.
Okay, thanks. It's now Mark McAllister from City News. Go ahead, Mark.
Thank you. Let me pick up on that, that sense of the need for new action and new plans. This is something that each of you has said. That's going to take a lot of time. How quickly can we start coming up with those plans and putting them in place?
Well, Mark, I think that's a great question. I think we've already demonstrated that there are a number of actions. The ones that can be taken immediately are already being undertaken, whether we're talking about increased access to testing or moving forward with respect to setting up supports like isolation sites. These are all active endeavors that we are pursuing right now. But what's really important here is that when we talk about health writ large, we're talking about fundamental change that will enhance and protect the health of our residents, not only from COVID-19, but from every possible emerging health threat, whether it's of a communicable disease nature or otherwise. And we are talking about addressing the social determinants of health, which, as you heard Dr. McKenzie say, is the result of the organized efforts of society. Yes, public health will play a role, but there are many, many other partners, most notably members of our community, that need to be active participants in that process.
Follow
That's
up?
all from me. Thank you.
Okay, thank you. Next up, we have Jennifer Pagliaro from the Star. Go ahead, Jennifer.
Hi, everyone. I wanted to ask about the long-term response. It seems to me, what I'm understanding from the comments and the data, is that we probably could have anticipated the types of communities because of the social determinants of health that we already know about. And I just wonder what should be happening in the long term. I know Mayor Tory spoke to this being something beyond the city's financial capabilities. Are we talking about the same types of requests we've always been making about housing and access to resources, and what can we start doing now, given that it seems we've let these groups of people down?
Well, you know, Jennifer, I don't know whether I would characterize them necessarily as the same types of requests. I think some of them may be similar to requests that we've made in the past, but I would like to think that given our experience with COVID-19, that perhaps they come with a little extra resonance and a little more specific evidence for their implementation. We've talked a lot about housing and how housing opportunities, affordable, healthy housing, is an important component. And certainly in the last several weeks, I've seen a lot of action here at the city on this front, and I anticipate that there will be more on that front, given its importance to health overall. But I will say this, it seems to me that as a city, and I would say globally, beyond the borders of Toronto, COVID-19 has really laid bare, you know, the inequities that exist. Certainly the inequities that exist here in our city, and I think it has provided us with a real window of opportunity to make some serious advances on health. This is what public health is all about, improving the health status and reducing inequities in health. This is the fundamental role of public health. It's not the sole responsibility of public health to undertake these things, but certainly we're eager and we're prepared to play a significant role in the work that has yet to be done.
And can I just quickly ask you, just in presenting this data to the public, I appreciate there's a lot of limitations and caveats here, which are also spelled out on the website. I appreciate that. When we're talking about the rates or the proportion of cases, I'm wondering what you think is most helpful for the public to understand. Should they be reading about this on a rates basis? I know your team has spent a lot more time with the data than we have, so I just wanted to ask about that.
Yeah, so that's an interesting question, Jennifer, and it's actually one that we puzzled with at Toronto Public Health ourselves. I think initially we had thought that it might be perhaps more usable for the public to focus on percentages, which is why we presented percentages first. But we opted to provide both the data, both as proportions and as rates, in order to give the most fulsome perspective. I don't know that there's a single wrong or right answer here, right? I think that, you know, having the opportunity to look at the data through multiple perspectives and in different ways actually just offers different opportunities to engage with the data. So that's why we opted to use both. But it's interesting that you raised this question, because this is something that we actually discussed quite actively. You know, in order for us to present the data, in a way that it would be usable and understandable to the population.
Thanks, Jennifer. Next up, we have Charisse Sheshuron from Globe and Mail. Go ahead, Charisse.
Hi, I think this question is more for Mayor Tory. You mentioned you were raising the subject of money and you're calling for funding through partnerships with other governments. I'm wondering what exactly you're looking for here, what you're envisioning.
Well, I think given the limitations that municipal governments across the country have in terms of financing a lot of the social initiatives that will affect the health, as we've seen from this data, of a lot of our residents, what we're looking for, if anything, is an expansion and acceleration of some of the things that have already been agreed to. You know, I think it's a real plus that we have for the first time in a long time, if ever, in the history of this country, a national housing strategy. But right now we're in the process, for example, of asking the very same government that brought it in, and I commend them for that, to accelerate thousands of additional housing allowances or rent supplements so that we can improve the housing of the very same thousands of people who will receive those. And we've seen, based on what has been said by our medical experts, that if people are living in more appropriate housing, better housing, helped by these housing allowances that are very much a part of the national housing strategy, that will have a positive impact on their health, among many other things. And so we're looking for governments, and I think whether it's on transit, which helps people get to opportunity, employment, which helps people better provide for themselves if they can get a job or a better job, housing, there's a whole host of things that we've embarked upon, including our efforts on anti-black racism, for example. I think to the extent to which you address all of these faster and more effectively, and I'm simply saying we can't do it alone. I think the citizens understand that. We certainly understand it in municipal government because we're left with very few tools to undertake at scale the kinds of things we have to do to address meaningfully the social determinants of health. But we very much want to do it and want to be good partners with not just other governments, but with community organizations and with the private sector. Private sector are key participants in this as well in a number of these areas where they can help us build more ingenious, affordable housing or do it faster. They can help us with employment opportunities and training opportunities for some of the people who are underemployed and therefore fall into these lower income groups. So I think it's a broad partnership, as we've all said.
Follow up?
Do you have a figure in mind that this would take?
Well, part of the problem I think we have is that we often will take it sort of silo by silo based on any one of these issues. So we've made some asks on different aspects that I've mentioned. We've made some additional asks on transit. We've had some generous help. But the fact is, on a lot of these areas, housing and transit being two good ones that can both affect this in a positive way, we took some decades off. Where, you know, one government was in, another one was out, or nobody was in making investments for the long term. So we're paying a price for that now. And so we have some very specific asks in front of governments for additional help with housing, or even just to accelerate some of the things that have already been provided for us so that we can, you know, show faster improvements in these areas. And so there are all kinds of numbers, but the real key is to sort of you know, make the decision on the part of all of us together, as we did so well during the pandemic itself, that we're going to keep these partnerships going, including with nonprofit organizations and the private sector, to make a difference. Food security is a great example. During the pandemic, we engaged in efforts far beyond what we were doing in the normal course. The need was there, but it was just terrific to see private sector, nonprofit sector, and governments and individual citizens all stepping up to address food security. Well, I've said this many times. One of the challenges for us now is to see if we can keep those initiatives, which were good and effective, going. And the more people that can benefit from those food security initiatives, somewhat financed by government, but not entirely, the better off those people are going to be in terms of their health and their vulnerability to some of these kinds of illnesses.
Thanks, Charisse. Next up, we have Scott Lightfoot from CTV. Go ahead, Scott.
Thanks, Lavin. One of my questions was already asked and answered, but I do have a question for Dr. Davila. In looking at the graph involving ethno-racial groups, I believe it was the first graph, each group appears to be disproportionately affected by COVID, with the exception of those who identify as East Asian. I'm wondering if this appears to be an anomaly or if this is something that's been seen elsewhere, and if there are any theories as to why this might be.
So thanks for the question. And just looking at the graph, making sure that we're looking at the same graph, it's not just East Asian. You'll see that those who identify as white are also underrepresented. And I made mention of that in my remarks. I can't say that I know specifically what the data from other jurisdictions show, but this is certainly what we're seeing in our city. And I think we will continue to delve a little bit further, and I will look, thanks to your question, I will see what else we find in other jurisdictions that have also gone to the trouble of collecting these data.
Thank you.
Okay, and lastly, we have Stephanie Smythe from CB24. Go ahead, Steph.
Hi, Mayor. Hi, Dr. Davila. My question is about the Ford government's school reopening plan for September. Part of it requiring all students in grades 4 to 12 to wear masks when they're indoors. High school students in Ontario's larger cities like Toronto attending classes on alternating days. There's additional funds for school boards, and mask use for smaller kids won't be mandatory, but encouraged. I don't know how much detail you have on this. I can start with the mayor and then Dr. Davila, but I wanted to get your impressions of what you're hearing from the province as kids are going to be going back to school in September.
I've had a chance to look through this and to have a discussion with the minister, and I will say that my initial reaction to it is one of gratification at the fact that young children in particular are going to be able to go back to school basically 5 days a week. And I think that that is important to their well-being, to their mental well-being, to that need for structure that kids have at that age to get an education. High school kids need that structure too, but I think they're better able to, chart a course for themselves to some extent. And of course, the young children are more of concern to parents who might themselves want to get back to work. The other thing that really impresses me about this proposal they put forward is the degree to which, obviously, there has been a very genuine collaboration between the public education and public health systems. You know, I think we've done so well, not perfect, but we've done so well at fighting off COVID-19 because there has been a collaboration with public health, and we've relied on the expert advice of those medical professionals, including, in our case, Dr. Davila. And I think what that has led to is better decisions, and I think this program today is better shaped and will produce a better outcome because, clearly, the government has listened to public health professionals on masks, on distancing, on some of the needs of young children in particular. So I'm impressed that they've come up with something that's quite balanced, and I'm sure their critics will help them to improve it further, but I think it's a very, very solid start.
Dr. Davila, do you have anything else to add? Okay. Did you have anything? Okay. Steph, go ahead. Second question.
Yeah, you can call this number back later.
Steph, follow-up question?
Yep, I'm here.
Yeah, go ahead. Follow
Okay, sorry.
Yeah, that's okay.
Well, you know what? Mayor Tory was saying that, it's high consultation with public health officials. Annie Kidder with People for Education was just on CB24 a moment ago, and she was commenting that, yes, there was all that consultation with the health professionals, but not industry professionals. To that end, Harvey Bischoff from OSSTF on CB24 earlier today saying that there's basically no consultation with the unions. Are you anticipating any kind of problem with this? Although the government denies that. They say there was plenty of consultation. But are you concerned that it's going to be trouble brewing, in a sense, with the professionals that work in schools?
Well, first of all, I think the two most important consultations that took place, and this is in no way diminishing the crucial role that educational professionals, educators have in making this all a success, were with parents of kids and with health professionals. And I think that obviously the parents are the clients in this case, whose children are the students in the schools. The health professionals, I think, made sure that the foremost consideration of the government, as I understand it, which was to keep these kids safe, was attended to as best could be the case. I pointed out that some of the critics, and we need critics out there to make us all better in terms of our decision making. I'm sure we'll have things to say that can improve this, and I'm sure that the concerns of the teaching profession will be taken into account as school boards and the government implement this, because they teachers and educators obviously have a huge role to play in this. But I think that I don't think there's ever been as widespread a consultation on anything as was the case with this, where thousands upon thousands of parents and others took part in indicating to the government what they were looking for. And of course, there was then the added help given by the public health professionals. But I'm sure the teaching profession, if they feel that they haven't had their views well enough heard, will have that opportunity now, because we've still got some time before school actually goes in.
Okay, that's it for today. Thank you, everyone. Have a lovely day.